This program is brought to you by Emory University.
Good morning, everyone. Welcome to another Grand Rounds. Just to remind everybody that at the end of this, you do have a CME link, so just make sure that you get your CME credit. It is my pleasure to introduce Dr. Charles Grodzin, who is an assistant professor in pulmonary and critical care here at Emory. He's received his medical training, including a chief residency year at Rush Presbyterian in Chicago. And during his training, he was a lead author of a textbook on diagnostic strategies for internal medicine that's been sold over 10,000 copies throughout the world. So his interest in medical education began very early. After completing his fellowship, he practiced in Chicago and then for about 15 years practiced in Dallas. However, because of his joy for teaching, he moved to Emory University in July 2014. And since being here, he's been the medical director of the Department of Respiratory Care and provides medical leadership for the pulmonary embolism response team, as well as lead physician for sepsis care. He's going to talk to us today about COVID-19 respiratory failure. So Dr. Grodzin.
Thank you, Dr. Mehta, for that. That's a very nice introduction. And thank you very much for having me this morning. It's a pleasure to talk about respiratory failure. And it seems that the COVID crisis is the topic of the day every day. And so this is going to be a little bit different for you guys, I guess, from the standpoint that we're going to talk about respiratory failure and the kind of experience I've seen both at Midtown in the COVID unit, as well as just coming off a week at Clifton for the COVID unit over there as well. And some of the underlying physiology of respiratory failure and how COVID has changed our management, or the impact COVID has had on our management. I have only this single disclosure. And today what we're going to talk about is some gas exchange aberrations, understanding acute respiratory failure and ARDS, concepts of lung compliance and some of the physiology behind gas exchange problems that we encounter in ARDS and how we deal with that. Discuss how sometimes our treatment can cause lung injury despite our best efforts. A general approach to ARDS, the hypercoagulability of COVID, such as it applies to our ICU care and our gas exchange abnormalities and respiratory failure, and some personal perspectives on what I have witnessed from the standpoint of taking care of COVID patients in a couple of different ICUs over the past 6 or 7 months. So acute respiratory failure, let's start there. That's in general, the respiratory failure of COVID is similar in most ways to that of respiratory failure from ARDS and the elements that lead up to ARDS, including lung injury. And so acute respiratory failure is still acute respiratory failure from that standpoint. We are gradually becoming aware of some of the pathological and histological and physiological difference with COVID patients. But by and large, apart from some of the studies that are going on, we really haven't changed our approach to ARDS. So what we're going to talk about this morning is a focus on the general standard physiology and the approach to treatment to ARDS and how that has been impacted by COVID through our experiences. I'm going to talk about the basic physiology that is altered, affecting oxygenation and ventilation, and point out that what we're really talking about here is the bottom line being an imbalance between ventilation and perfusion. So, why won't my slide go forward? Oh, sorry. So the definition of respiratory failure. Classic definition of respiratory failure would be the inability to maintain an oxygenation and ventilation within a range of the normal variant, or the people that are generally abnormal but not in respiratory failure. So if you can't maintain a PO2 above 60 millimeters of mercury, if you can't maintain a PCO2 less than 60 millimeters of mercury, then either of both of those would constitute respiratory failure. Not everybody with respiratory failure is necessarily in the hospital or in the ICU. Our clinics in the pulmonary side of things are full of people in respiratory failure all the time. So we have to take into account that there are patients that have chronic lung diseases that have baseline CO2 retention that are able to compensate for that hypercarbia, but not be necessarily requiring inpatient stay. And I want to point out that respiratory failure, although we focus on the carbon dioxide levels from a ventilatory standpoint, is really about pH, because the overt respiratory failure occurs when the body is no longer able to maintain the compensation for chronic hypercapnia, and the pH falls off as the accumulation of CO2 becomes overwhelming, and the compensable mechanisms are no longer able to keep up with that change. So when that happens, the pH falls disproportionately, and you probably all seen the Davenport diagram at one point in time. And those folks that have chronic respiratory acidosis will develop acute respiratory acidosis as the CO2 rises and the pH suddenly falls significantly in from that 7.3-ish range, which is generally where compensation will maintain the pH, down to the 7.25, 7.2, 7.15, et cetera, or lower, depending on the degree and how fast that CO2 accumulates. So the point is that when someone brings to me a blood gas, I am much more concerned about the pH than I am the PCO2, because the compensation will for a long time be able to maintain that pH until it doesn't anymore and it falls rapidly. Another way of defining acute respiratory failure in the ICU is by end-tidal CO2 trending. So end-tidal CO2 is a modality that we use to reflect both adequate perfusion and ventilation. So given stable perfusion parameters, an escalating trajectory without a plateau is a representation of hypoventilation, and highlights the difference between dead space ventilation and alveolar ventilation, and becomes the basis for the rapid shallow breathing index, which I'll talk about in a little while. When we take people off the ventilator, for example, and follow their end-tidal CO2, or we're trying to use the end-tidal CO2 to determine who requires mechanical support, I'm not particularly concerned about an end-tidal CO2 that's above their baseline, as long as it plateaus. If it doesn't plateau and continues to rise in an escalating trajectory, that constitutes perhaps an early sign of someone who will eventually decompensate and go into overt ventilatory respiratory failure. So here's an end-tidal CO2 capnogram. And just to demonstrate, for example, the dotted line being your normal end-tidal CO2 curve during the expiratory phase of breathing, with the end-tidal CO2 measured at the end of the tidal breath. At the end of the tidal breath, the next inspiration occurs, and we repeat the same process. For people that have, for example, chronic airway disease, the slope of the phase 3 rise of the expiratory plateau changes quite a bit. And so people that are experiencing CO2 retention with escalation of the end-tidal CO2 will have a change in their end-tidal CO2 curve that moves from the dotted profile to the solid profile. And this increase in slope, or this quote unquote shark finning, is something that we can look for besides the numbers to determine if someone is moving in one direction or the other. Obviously, it goes both ways. Someone who's in acute bronchospasm and respiratory failure, for example, may demonstrate this shape. And as they get better and we treat them with bronchodilators or steroids over time, they may then move to this shape, or sometimes we can see it transitioning from one to the other. The third type of definition of respiratory failure is kind of like, you know it when you see it. And so this is when you see someone who has rapid shallow breathing, for example, who is breathing such that the movement of air is ineffective at either excreting CO2 or transmitting oxygen to gas exchange units. This gets into the rapid shallow breathing index, which I will come to in a little bit and explain where that comes from. We see diaphragmatic dysfunction, or Hoover's sign, which is a paradoxical movement of the diaphragm such that, hold on, something went wrong. Sorry about that, just technological problems. Anyhow, diaphragmatic dysfunction occurs with paradoxical movement of the chest and the abdomen. And visually, this is a sign of respiratory failure, where what you see is that because of the diaphragm dysfunction, the actual chest and abdominal movements move inwards as opposed to outwards during the inspiratory phase of breathing, which means that they are working against the individual's effort to expand their chest, push their diaphragm lower, and push out the abdomen, which is generally what happens when we take a breath. So when this happens, it's an additional load of work and energy that's required, and is physiologically disadvantageous to breathing. So you can visually see this, for example, if it's very overt, or sometimes the best way to see paradoxical breathing is to put your hand on the patient's chest or abdomen and just feel which way the chest moves. It doesn't make any sense for when they take a breath for the chest wall to move inwards. So sometimes you can feel it over the abdomen as well. Tripoding is a stance that we'll find a patient sitting in, for example, when they're in respiratory failure, where they're trying to place accessory muscles and other respiratory muscles at a better physiological advantage. And generally, this is the person sitting on the side of the bed with their hand on their knee or on the bedside table, trying to support themselves. One of the phenomenon I've seen over the years is that when you talk to people that have chronic respiratory failure, they say something like, I can go to the grocery store and I can walk around the entire place, but I can't walk from room to room in my house. And what this is all about, similarly to tripoding, is that when they use the grocery cart, for example, and hold on to it, it's actually simulating this type of body position such that it's advantageous for their breathing to use the grocery cart, or even a walker for that example, to place respiratory muscles at a better advantage. So this is what someone who's sitting on the bedside is trying to do on the bedside table, or hands on knees, that kind of body position. Obviously, you might come across someone who can't even complete a sentence without having to take an extra breath or even individual words. Also, things like diaphoresis, altered mental status, a reduced level of consciousness, and myoclonus in particular can be seen at higher levels of hypercapnia with muscle contraction. And I've seen that be a significant manifestation of respiratory failure. So the rapid shallow breathing index I've mentioned a couple of times. And the underpinnings of this is that the total ventilation is really equal to the alveolar ventilation and the dead space ventilation. And for balance of your carbon dioxide, the only real variables that you can control are how fast you breathe and your tidal volume. You can't control your dead space so much because it's dead space is defined by the areas in the bronchial tree which do not participate in gas exchange, for example, the tracheobronchial tree. So when you develop a lung disease where you have consolidation or ARDS or pulmonary edema, where now a lot of the lung parenchyma is no longer involved in gas exchange, you have a relative increase in dead space. That area will be perfused, but it will not be ventilated. So as alveolar ventilation is then limited further and further by this increasing lung problem, CO2 excretion becomes more limited. And as I said moments ago, the only other thing the individual really has most control over is frequency. So to control their CO2, they will breathe more rapidly to make up for the reduced alveolar ventilation. And the rapid shallow breathing index, it really measures how that frequency increases over the tidal volume, which is decreasing. And so the higher the number, the worse. Obviously, the ratio gets larger if your frequency of breathing is higher and your tidal volume is lower. We use this with a cutoff of 105 as the means by which to determine whether or not respiratory failure is getting better or getting worse. We use it, for example, in determining who might need to be placed on some sort of ventilatory support, whether invasive or non-invasive. And we also use it to determine someone, for example, who's on a ventilator or other type of ventilatory support who may be improving so much so that we can extubate or move to a lower level of support. But it's really that balance between dead space and dead space ventilation and alveolar ventilation, which we focus on and recognize that our gas exchange is going to be limited when the alveolar ventilation is imbalanced and reduced. So that leads us to ARDS. And ARDS is generally defined by what we have always taken as the Berlin criteria. So ARDS actually has several particular factors. It needs to be something that happens within a week of a clinical insult with new or worsening respiratory symptoms. New meaning someone who may have no other previous underlying lung disease, or worsening symptoms meaning someone who, for example, has underlying lung disease, and we see that based on their baseline of respiratory insufficiency that they're somewhat worse. We need to see on imaging bilateral opacities that are not fully explained by the presence of pleural fluid, lobar or lung collapse or atelectasis, or any kind of nodularity. Generally speaking, the imaging findings are more of a bilateral ground glass nature, as I'll show some examples in a little bit. And the origin of edema is not explained by cardiac failure, fluid overload, nephrotic syndrome, renal failure, things like that, severe hypoalbuminemia. It's not a volume or a fluid overload situation. And that may require some needed objective assessment like echo or other testing to determine if any of those other problems are present, so that we're not including any simple hydrostatic edema and calling that by mistake ARDS. And ARDS is rated as mild, moderate, or severe by what we use is the P to F ratio. So the PaO2 over FiO2. So in other words, the worse the situation, the lower the PaO2, the higher the FiO2, and therefore the lower the ratio. So mild ARDS is when the P to F ratio is between 2 and 300, moderate between 1 and 200, and less than 100 is severe ARDS. The only caveat is that those P to F ratios are taken with PEEP or CPAP at greater than or equal to 5, which is pretty much commonplace, so it doesn't really become an issue as far as meeting that criteria. So ARDS features patchy disease, a spectrum of shunt to normal VQ relationships, a proteinaceous alveolar filling or hyaline membrane disease that is non-cardiogenic and has no other previous or additional cause as mentioned on the previous slide. So just to remind folks that is on a model basis here, we have an alveolus with normal ventilation and perfusion. We have an alveolus here that has a airway disease associated with it, so that this alveolus is perfused but not ventilated. So this would be generally called a shunt. And also over here we have an alveolus that has a blood flow abnormality, could be a pulmonary embolism or something like that, where there's a VQ imbalance and VQ mismatching occurs. As we go from normal to shunt, this is the type of situation where we have perfusion without ventilation. And so this becomes dead space, to link it back to our previous discussion. The more dead space accumulates, the less we have the ability to exchange carbon dioxide, the less we have the ability to oxygenate appropriately for that vascularity that's associated with this alveoli or the alveolar units that this represents. And subsequently, when a lung injury occurs, there are structural consequences, dysfunction of surfactant, dysfunction of alveolar lining cells. There are biological alterations with numerous toxic cytokines and mediators, and there are systemic effects that lead to damage of the lung. I'm not going to go through all of this in detail, but The point is that there is a cascade of events that occurs once the lung injury begins that can lead to ARDS under the right circumstances. So on imaging, bilateral opacities, and it may be a little, and I did just mention that it's patchy disease, but what we see, even though the chest X-ray looks like bilateral opacities, that when we look at a lot of these patients with additional imaging, for example, CT, we do see definitely a bilateral involvement, but there are some areas of lung that are denser, that have more areas of consolidation than others. And some areas may look almost normal. But what you do see is the spectrum of areas of consolidation, such as in this scan, to areas that are less affected. Obviously, if we go back to the discussion about ventilatory sufficiency and alveolar and dead space ventilation, these areas of the lung are being perfused, as we can see blood vessels here outlined by contrast, but we're certainly not ventilating them. So on our alveoli model, as I mentioned, we talked about a few minutes ago, you can certainly see which alveoli these are. And we can also recognize that there are areas of the lung that aren't affected as badly. So when we talk about ventilation and perfusion, what we really have to think about is not on an alveoli to alveoli basis, but to recognize that this lung and in this particular patient really spans all of the VQ relationships, some obviously very poor, some obviously better. Another example of where we have some areas of dense consolidation and areas that are less affected, and maybe even some areas that may yet be normal. So what I want to point out is that though ARDS looks like a diffuse injury, and it is not necessarily equally affected throughout all of the lung fields. Lung injury in general occurs at a number of places. And the last thing we want to do when we ventilate someone is to add more insult to injury. They don't need anything worse happening to them. And so where we focus on physiologically when we ventilate patients is explained by this picture. This is a compliance curve. This is the ventilation, volume, change in volume, and the x-axis is the change in pressure. And this compliance curve represents lung compliance. Now, to go through this in a little more detail, if you've ever blown up a balloon, you've recognized that at the very first moments, it's a little difficult, then it gets a lot easier, and then it gets harder again. The lung is very much the same way. When we are in this range of the compliance curve, we may apply pressure without much volume change. Similarly, at the top of the compliance curve, we apply additional pressure without much volume change. But you can see here between, which is labeled as B, when we apply more pressure, we get volume easily. And so when we want to ventilate people, we want to ventilate them between, and on this component of the compliance curve. So I've labeled PEEP here. So PEEP, being positive end expiratory pressure, is defined as not simply just positive end expiratory pressure, but it's where the compliance curve shifts from applying pressure with no volume change or no significant volume change to pressure with a significant volume change. So the application of a lower inflection point here, where we identify PEEP, keeps us from this part of the ventilation, pressure volume curve. Similarly, when we target a plateau pressure of around 30 and stay below that in this range, it keeps us from another flat part of the compliance curve so that we're not applying undue pressure without ventilatory benefit. So when we ventilate between PEEP and plateau, we stay on the steep part of the compliance curve. Lung injury occurs on this range where alveoli, my crude representation of crowded alveoli that are closed and not opening, and as they stick together, they damage each other. And lung injury occurs up here, again, on the flat part of the compliance curve where alveoli are overstretched. But in the middle of the curve where we ventilate, alveoli are open and stay open throughout the ventilatory cycle. They may change size or shape when we have an inhalational phase versus an exhalational phase, but they don't close as they do here, and they don't overstretch. And so when we stay in this part of the compliance curve, alveoli are at their maximal useful size. We're going to see a little more on the compliance curve a little bit later on as well. So lung injury, is to just go back a little bit from what I was just saying, happens either below the lower inflection point where additional pressure doesn't yield volume, which is then not effective. And this is below the PEEP inflection point. And the upper inflection, and lung injury also occurs above the upper inflection point where alveoli are stretched, damaging alveolar endothelial cells. And this is above the plateau pressure inflection point, which we try not to violate. And surfactant, as well as a protective protein that lines the alveolar surface, is lost, as are a number of the other damaging events that I noted in that busy slide a little earlier that continue to happen. How do we treat ARDS? ARDS is a tough one. So first of all, oxygen therapy, nasal cannula oxygen, an oximizer. An oximizer is a oxygen reservoir that here at Midtown we call it a mustache because it sits on, it's kind of where your mustache would be. Sometimes it comes as a pendant, but it's the equivalent of the non-rebreather mask bag for a nasal cannula. Usually it's worth about an additional 4 to 5 liters of oxygen. Non-rebreather mask, that's a little bit higher on the pecking order. High flow oxygen. So high flow oxygen is not the green tubing. It is not when you have 12, 13, 14, 15 liters per minute. That is what we would call higher flow, but not high flow. High flow really is more than 20 liters using either an Airvo type machine or a OptiFlow, which can go to 20, 30, 40, 50, 60 liters per minute, providing a small amount of PEEP, providing a tremendous amount of flow. The more flow, the easier it is for the individual to inhale and saves their energy and helps them to continue to have gas exchange without requiring non-invasive ventilation or mechanical ventilation. On a non-invasive ventilation perspective, we have BiPAP and CPAP, but we have not been using that for our COVID patients because the risks of aerosolization, as it's not a closed system. There are a number of different brand names for BiPAP and CPAP. All of the systems that have been at risk for aerosolization or are not closed systems have not been used for the COVID patients because of our concern about aerosolizing transmissible particles. And of course, we have mechanical ventilation as sometimes and often where we need to go for patients that have ARDS. Mechanical ventilation, obviously, as I said before, the main goal is support without additional lung injury or VILI or ventilator-induced lung injury. So we generally have tidal volumes of say 4 to 8 milliliters per kilogram. We generally are around 6 as what we try to avoid, as what we try to aim for. Generally, we're on ACVC or ACVC plus, which is a volume controlled ventilator mode where we set the volume and the rate. The only difference between the ACVC and the ACVC plus is that for patients that take spontaneous breaths, the plus setting helps them with flow support. If patients are fully sedated or paralyzed, the plus doesn't have any value whatsoever. We try to keep the inspiratory to expiratory ratio greater than 1, meaning 1 to 2, 1 to 3, 1 to 4, so that there's plenty of expiratory time for the exhalation of the tidal breath, and we avoid auto PEEP. We use a descending ramp, which is generally more comfortable as it approximates the way we breathe from the standpoint of how we accept our tidal volume. We use PEEP at or above the lower inflection point, as we mentioned previously in our compliance curve. And we try to keep the plateau pressure below the upper inflection point so that we maintain the ventilatory cycle on the steep part of the compliance curve. And to avoid ventilator-induced lung injury, we try to keep our plateau less than 30. We try to keep our driving pressure less than 15, the driving pressure being the difference between the plateau pressure and the PEEP, which really represents, again, the volume given to the patient on the steep part of the compliance curve as the PEEP is the lower inflection point and the plateau is the higher inflection point. Just to revisit that, so your driving pressure would be the difference between your plateau pressure and your PEEP. And we know that when we keep this less than 15, that we have a mortality benefit. Just to bring that back to the compliance curve. What other methods do we have of treating ARDS? Well, proning. Proning is one of the things that we've known about for some time. It's not a COVID-associated approach, but we have been proning people more often because we've been seeing a lot more ARDS. We tend to move to this when patients have a P to F ratio of 100 to 150, being in that severe to intermediate range, but on the severe end of the ARDS, mild, moderate, and severe assessment. It allows for redistribution of the ARDS edema. As we look back at those CTs that we showed, and we saw that there was dependence. And as we turn someone over onto their belly, some of that edema rebalances itself and flows so that we are in general improving the VQ balance across the entirety of the lungs gas exchange units. It also allows for a better distribution of PEEP. You can imagine that in someone who has a CAT scan where there's very dense dependent edema, that the pressure across the entire lung is not equal and probably flows more to the areas that are already ventilated as opposed to the areas which are consolidated. And this is not necessarily helpful. If we can't flip the patient over, we can put the 5-liter saline bags on the anterior chest wall to stiffen it. One of the mechanisms by which proning works is by equalizing the anterior and posterior chest wall compliances. They're not the same under normal circumstances, but when we flip someone over on their stomach, we are able to provide much more stiffness to the anterior chest. And when that happens, the distribution of PEEP and the distribution of pressure in general is more equally balanced. You can prone someone as many times as you need to. We do 16 hours prone, 18 hours rest, and we do that every day until we have improved the general ventilation perfusion balancing and improved oxygenation. So just as a little bit of an example of how proning works, if you have, and I'll ask you to excuse my artwork, in the supine position, if you were to have, for example, a bicycle tire with a weak area and you applied pressure to it, that pressure would be unequally distributed and outpouch or diverticularize this part of the weak bicycle tire wall. If we turn the patient over and put this weak segment on the bed, such as we've done here, where the weak segment is represented here, it is not allowed to pouch outwards, as we saw on the previous slide, and the application of pressure is generally applied. So if you expand this type of example to the lung, you can see how this is a better situation where we have PEEP and pressure applied generally more equally across the entire lung, across all the lung units together. Another approach to ARDS is paralysis, generally in the first 48 hours for 48 hours. The problem we run into is that many times when we've got people come to the ICU from the medical floor or from other places, we don't really know when they got sick exactly. So we start the clock when they come to us. The paralysis also improves lung and chest wall compliance through muscle relaxation, and again has an impact of distributing pressure more uniformly. It also reduces metabolic needs and augments sedation. We've talked a lot about PEEP. PEEP we use as a recruitment maneuver to support gas exchange units, and we can optimally determine what the lower PEEP should be by generation of a compliance curve and using ventilator graphics. We can see the success of oxygenation, which allows us to reduce FiO2. And we can see improved compliance if we were to create that compliance curve, as I've mentioned before and talked about several times. Just to point out again, PEEP would be at the lower inflection point and plateau at the high inflection point. Now, in someone, this being a normal compliance curve, when someone develops ARDS or restrictive lung disease, we can see that our inflection point moves laterally from a normal compliance curve to a compliance curve that features reduced compliance, for example, ARDS, such as the context of this presentation. And when the inflection point moves from left to right, you can see that that's an increase in PEEP. And so people that have worsening ARDS may need 6 or 8 or 10 or 12 or 14 or 16 or 18 or 20 centimeters of water of PEEP as the compliance gets worse. And this is exactly why that happens, because the lower inflection point moves further and further to the right as the lung is stiffer and stiffer. The benefit of driving pressure, as I mentioned before, which is again the difference between your PEEP and your plateau, is we try to keep the driving pressure less than 15. This is the underlying data from Amato in 2015 that noticed the fact that if you look at airway pressures across the top and relative risk of mortality across the bottom here, that the only arrangement of PEEP and plateau that affords a mortality benefit is when the PEEP and plateau are less than 15, when you less than 15 centimeters of water apart, therefore the driving pressure being less than 15. Mechanical ventilation and other ideas. We certainly need to control that plateau pressure and driving pressure by making ventilator changes, reducing the tidal volume, diuresis, paralysis, etc. The PEEP and the peak pressures are not thought anymore to be risk factors for barotrauma. Permissive hypercapnia can be employed when you have a very stiff lung. For example, if pressure is overwhelming to achieve a certain CO2 and pH relationship, we can let the CO2 rise by reducing volumes to avoid plateau pressure violations and have allow for a lower pH that's associated with that hypercapnia to a degree. pH in the 7.15 range is okay if we need to limit ventilation because our plateau pressure is very sensitive. We try to avoid auto PEEP by adjusting tidal volumes, flows, and respiratory rate. We try to keep that I to E ratio or the inspiratory to expiratory ratio greater than 1 or a minimum of 1 to 1 in order to allow for ventilation and avoid auto PEEP. Sometimes we can, if we need to, change that ratio to 1 to 1 or even invert it to have longer inspiratory times and augment PEEP alveolar recruitment. We can also use pressure control as a different mode if the plateau pressure limits our tidal volume. However, recall that as the lung gets stiffer and we avoid higher pressures, we will, based on compliance, have lower volumes and probably have higher CO2s and lower pHs as tolerated. Pulmonary embolism occurs. It's a little harder to diagnose micro and macrovascular thrombosis in COVID. Macrovascular disease, we take COVID to be a hypercoagulable state, but many times we can't send people for CAT scans because of the paraphernalia and also because many of them also incur renal failure and can't have a contrast load. So often the circumstances of when we start to suspect PE are the equivalent of massive or hemodynamically unstable situations. These are patients already on pressors, fluids, etc. And so if they've had a PE, we may assume that that all of their instability is from that or part of it, but we don't know. It's hard to parse out how much could be from a PE that we can't diagnose from their underlying ARDS from COVID. Point of care ultrasound can show right heart enlargement, sometimes a clot in transit, but often not. And so the right heart enlargement can be from a number of factors, including ARDS, increasing pulmonary vascular disease or PE, but certainly it's not specific. The microvascular component of thromboembolic disease can be on a clinical basis of otherwise unexplained organ failure, for example, or maybe additional end organ damage on top of organic disease. We see encephalopathy, acute kidney injury, all of which can be microvascular-based organ failure. We have an anticoagulation protocol based on D-dimer, which is this document, which I'm not going to go through in general, in specific, but it is how we try to choose our anticoagulation based on D-dimer and other factors that recognize that COVID is a hypercoagulable state. So most people are already anticoagulated, but sometimes we have issues where we have to choose other agents like the direct thrombin inhibitors, etc. We can't transport people due to paraphernalia and transmission issues for the COVID patients. And do we sometimes choose to use TPA? Yes, and we have, but it's out of context without a specific diagnosis, but we do take on the bleeding risks. There is some discussion about whether the dose could be different for these patients, the duration of the infusion can be changed, or how do we follow up and transition to what anticoagulant after thrombolytic therapy. Plasma exchange is another possibility that we've been using in the COVID patients and respiratory failure, which is thought to be based on hyperviscosity, where the presence of D-dimer, fibrinogen, and other clotting proteins is thickening the blood. We see D-dimer ranges up to greater than 60,000 at times. So we're replacing the thick viscous plasma with better viscosity for microvascular flow, but we don't really know how long this impact lasts, and we're not sure that it really has much impact across the board. We see pneumonia with the use of steroids and superinfections. We try to practice antibiotic stewardship, and we have procalcitonin levels available to us, but they're not really clinically useful in a viral lower respiratory tract infection. Some of my observations is to maximize your PEEP use. Don't be afraid to get that PEEP up there and taper your FiO2 when the PEEP recruits alveoli. When the PEEP is functional and improves gas exchange and places you on the better part of the compliance curve, keep it. Reduce your FiO2 and don't worry about the PEEP until later on. Low threshold for anticoagulation and suspecting thrombosis. I've seen that the encephalopathy is severe with patients needing up to sometimes half a dozen sedation medications at one time to maintain their sort of calmness and comfort. With multiple high doses of sedatives are needed. Obviously, we haven't had much success with hydroxychloroquine, steroids, or plasma exchange at this point, and there are studies ongoing that are still gathering data. And although it seems like we've had COVID around for a long time, from a data standpoint, we really haven't. So with that, I believe I'd like to stop, and I'm happy to take any questions at this point. I'll turn it back over to you, Dr. Mehta.
Thank you so much, Dr. Grodzin, for that outstanding teaching. We really appreciate you taking the time this morning to review all this with us. Any questions from the audience? You can type them in the chat box or text me. Everybody's processing the lung pictures and compliance. I have a question. So it sounds like, as far as if it's a COVID positive patient, once they have ARDS, all the treatment and everything is similar to how you would treat an ARDS patient. But your suspicion for looking for a PE or a clot, you're keeping that higher. But is there anything specific that is done differently if they're COVID positive currently?
Well, so in general, the ARDS approach is still the ARDS approach. The places where COVID adds a unique factor would be things, so like, for example, proning and paralysis are things we've done for a long time in terms of ARDS and the need for those maneuvers, which have a mortality benefit. The thrombosis issues, particularly the macro and microvascular thrombosis issues, are something that the COVID crisis has brought into focus from the standpoint that we necessarily would put people on DVT prophylaxis when they're on a ventilator, for example, but we wouldn't necessarily either choose other agents like direct thrombin inhibitors or TPA, or even fully anticoagulate with heparin or Lovenox under normal circumstances. The PE element of this makes it is very complicated from the standpoint that we often treat for PE without really knowing it's there, because we find factors and findings that are suggestive. For example, someone who, for example, is doing much worse all of a sudden, or has an abnormal point of care ultrasound where we see right heart chamber enlargement. We really won't see the clot. It's hard to find the clots, but a lot of the clinical decision making is really done at the bedside from that standpoint. So that's a little bit of a different thought process than we would otherwise go through in a non-COVID patient. The plasma exchange and monitoring viscosity levels is something that we generally don't do for ARDS. But if if we talk about that ventilation perfusion disparity in ARDS, anything we can do to rebalance those is something that we need to pursue. So plasma exchange might be useful. It might be able to help end organ dysfunction recover faster. We just don't know. It's going to be some time before we have that kind of information to be able to make a choice about plasma exchange. For example, the steroids, some people believe in steroids, some don't. There's one trial that was really a non-randomized small trial of steroid therapy that came up with really, really good survival benefit, but it's not been reproduced. And we have seen a lot of superinfections and bacteremias with gram-negative organisms. And so depending on who you ask, they may or may not like steroids. I saw steroids used much, much more over at EUH than we were doing them at Midtown. It may just be a style of practice, but as to whether there's a survival benefit, it's a little bit still hard to know. There is a study going on for radiation therapy, actually at Midtown, for those that have early COVID pneumonitis. Don't know about that yet. That's something that is ongoing. It's still early. I might plug the Pulmonary Embolism Response Team Consortium COVID database, for which we're trying to contribute patients for this reason from a pulmonary embolism standpoint. The more that we can build out that database, the more we might be able to have more answers to these questions right now. But what we do know is that our longstanding ARDS therapy to paralysis, proning, and the use of PEEP for alveolar recruitment and keeping an eye on driving pressures are things that have been successful in the past, shown mortality benefits, and are the main thrust of treatment, COVID or non-COVID ARDS.
Okay, great. And then what about in the outpatient settings? So a lot of these patients who, were COVID positive or, recovered, what kind of abnormalities? I mean, are they having sort of persistent PFT abnormalities, persistent shortness of breath? Because one of the things from a cardiology standpoint, we see a lot of patients who complain of shortness of breath. And so what are your thoughts on that?
Yes, so we have started to see a number of patients come through as outpatients, either in our clinic or in the post-COVID hospitalization clinic, and it's across the board. It doesn't seem that there's any one profile of a post-COVID pneumonia patient who is in the midst of recovery. Some have an underlying bronchospasm disease that requires an approach similar to what you would do for asthma or COPD with a more of a chronic bronchitis profile. Some of them have shortness of breath that resolves slowly as they continue to have some infiltrates, but it's well known for people that have pneumonia or lung disease that the X-ray takes much longer to improve than the patient. So we see people that have abnormal chest X-rays that persist for some time, and it's not clear as to whether or not they will actually come back to their previous baseline. I suspect that if they will, it will take some time, but if they had an underlying previous lung disease, it's unlikely, I think, that they're going to, come back to their baseline. From a pulmonary standpoint, we do see ongoing symptoms for some time, and the only treatments that we really have are symptomatic therapy, or a cough or for bronchospasm. In people that have more serious problems, maybe low-dose systemic steroids, although obviously that's not a very satisfying answer. And then surveillance and longitudinal care in order to, kind of observe their trajectory. But I would also say that it's not known. When people ask me, say I had COVID and I'm short of breath, one of the things I have to tell them is that we don't know because we just haven't had the time and the experience yet to fully understand the broad spectrum of COVID, seeing as though it's only been around for a short period of time. It seems like it's been around for a long time, but as I said earlier, from a data standpoint or an experience standpoint, it's still quite early.
Great. Any questions from our audience? Okay. If there are no more questions, I think we've learned a lot about the pulmonary aspects, and you've given us some things to think about. Thank you so much again, and I'm going to go ahead and close the grand rounds, and I'll see everybody next week. Thank you.
Thank you for having me. Appreciate it.
The preceding program is copyrighted by Emory University.